am also the next speaker. So just for those of you who don't know who I am, so I'm Chantal Scott, also an HPCSA registered genetic counselor. From 2013, I've been in private practice for probably like 5-6 years already. So I practice in the northern suburbs, and I'm based at the Panorama Center for Surgical Oncology. So I'm going to talk a little bit more about how to sort of deal with a positive genetic test result. I'm going to focus specifically on the BRCA1 and the BRCA2 genes, as well as the ATM gene. And then Frida is going to talk more about the CHEK2 and the PALB2 genes. The reasons why we selected those genes is because you could have seen from the previous slide from vaccine, those are the ones that we see most often in our population group. So just some important points before we talk, so just a few concepts. So the talks are going to be about, when we talk about a positive result, we mean testing germline testing, so not somatic testing, and we mean that a likely pathogenic or pathogenic gene variant has been identified. These are not the guidelines for variants of uncertain significance. Also, just to note that if you do have these gene variants, it does not mean that you will definitely develop a second cancer or a primary cancer. It means that you are at an increased risk. And I've just put up the Knudsen's two-hit hypothesis there to explain that in a little bit more detail, just to say that if you've got a gene variant, you're born with one allele that is faulty, and the other one also needs to lose its function, and that usually happens from outside factors that influences that one and causes a mutation. There's not enough time to explain that in detail, but we will, if you have questions about it, I'll explain it later. I'm also going to present the management guidelines based, so the international guidelines. We don't have our own South African guidelines. We usually base it on the NCCN or the NICE guidelines. And just to say that all of these management guidelines that I'm going to present, they are guidelines. They're not a one-size-fits-all. It needs to be individualized according to each patient, their family history, and their personal risk factors. Okay. So to start off, so BRCA1 and BRCA2, I'm sure most of you have heard about these genes. They're sort of like the famous genes made famous by Angelina Jolie. So they are known as tumor suppressor genes because they play a very important role in cell growth, monitoring cell growth. And they also play an important role in repairing damaged DNA. So this is a summary of the cancer risks that's associated with both genes. I'm not going to go into it in detail because everyone can read, but just to highlight a few important things. So with both a BRCA1 and a BRCA2 gene for women, the two most important risks are for the breast cancer. It's a high risk for breast cancer if you're positive. For BRCA1, it's up to 78%. For BRCA2, it's up to 80%. It might be higher depending on the family history of that patient. And very, very importantly, if you've already had one diagnosis of breast cancer, if you carry one of these genes, there can be an up to 50% chance of you getting a second primary breast cancer. There's also important to highlight the male breast cancer risk associated with BRCA2, as well as the high prostate cancer risk for men associated with BRCA2. And then for women, we go back to ovarian cancer. That includes fallopian tube and peritoneal, so it's not just the ovaries. Very high risk with BRCA1, up to 65%, and BRCA2 can be up to 46%. And then two other cancers, which I think people sometimes miss in these carriers. The one is pancreatic cancer. So you can see there's an increased risk for both BRCA1 and BRCA2. There's also an increased risk for melanoma in both BRCA1 and BRCA2. The evidence is still preliminary for BRCA1. So I wouldn't necessarily give recommendations for that type of cancer screening, but it is elevated in BRCA2 patients. And interestingly enough, in our South African population group, we seem to see quite a lot of people that are carriers for BRCA2 that are diagnosed with melanoma. So I do think that elevated risk of more than 2% is probably higher in our population group. Recent studies have also found preliminary evidence that there's a slight increased risk for serous uterine cancer associated with BRCA1. Just to caution everyone about that, I think there's only about 2 studies that have said that, and I found there's other studies that have actually said that's not the case in their cohort. So I can tell you now that cancer risk is also going to be something that's going to be population specific and gene variant specific. So I would be very cautious about that risk. Then what is the general guidelines if someone is positive? So I'm using Invitae's general summaries that they give, because it's based on the NCCN guidelines that we often use. And I'll just add a few things. So basically for breast cancer, if you're positive, then you would have to start self-examinations and breast awareness at the age of 18. Clinical breast examinations every 6 to 12 months from the age of 25. And then from the age of 25, you should start breast MRI. And then you should also, from the age of 30, start annual mammogram. So it would be MRI, 6 months later, mammogram, 6 months later, MRI. And then just also say that, yes, the screening is generally started, the breast surveillance imaging is started at the age of 25, but obviously if there's a family member that presented with a breast cancer at a younger age, you would start screening at a younger age. Very importantly, so for women who are positive for a BRCA1 and a BRCA2, risk-reducing bilateral mastectomies is recommended at the appropriate age, and obviously once they've completed family, if they would like to breastfeed. It is definitely recommended if you've already had a primary breast cancer. So that is definitely a recommended guideline. And then for men, so this is the same for BRCA1 and BRCA2. We often forget about the men, but they should actually also start doing self-examinations of the chest area from the age of 35. And they should also go for clinical examinations at that same age. And then if you've got a man that has a lot of extra breast tissue, gynecomastia, or they've got a family member who was diagnosed, a male family member who was diagnosed with breast cancer, you should actually also consider mammograms in them. I've also put a little note there about chemo prevention, but we don't generally do that in South Africa, but there is some studies that have mentioned the use of low-dose tamoxifen for about 5 years in patients who are BRCA1 positive, and it's usually been offered to women who are postmenopausal and healthy. Okay, that is as an alternative to surgery, because some women who are older do not want to go for the risk-reducing bilateral mastectomy, so it is something you could consider. To go further, so the recommendation for ovarian cancer is, this is very important. So the screening guidelines or the surveillance methods that we have for ovarian cancer is not very effective in detecting the ovarian cancer at an early manageable stage. So they would definitely recommend to rather do the risk-reducing salpingo-oophorectomies at the appropriate age. So for BRCA1, it is to be considered from the age of 35 to 40 or after you've completed your family. Because that is the most effective way to actually deal with that risk. They also note that for women who are BRCA1 positive, you could now consider the option of a hysterectomy because of that potential risk for uterine cancer, but I would be very careful about that. Okay, so I said they say you can discuss that option with them when they also have to go and have to do the risk-reducing salpingo-oophorectomy, so that you time it at the same time. For prostate cancer, what you would usually do, so for men who are positive, you would start annual prostate cancer screening from the age of 40. And you would also then do the PSA level blood test and also the digital rectal examination. For pancreatic cancer, the screening should only be considered for individuals where there's a family history of pancreatic cancer, where they had a first degree or a second degree relative that was affected. So the screening is not recommended if you don't have a family history of pancreatic cancer. And it also has to be on the side where the gene has actually been identified. So for them, you would then consider annual MRI or the MRCP or the EUS, starting from the age of 50, or if there's a family member that was affected younger than the age of 50, you would start 10 years younger than that. Then for the melanoma risk, you would, so there's no set guidelines for that, especially because with BRCA1, it's still preliminary evidence. But they do say there's no harm in doing like population risk type of screening and to recommend annual full body skin assessments, as well as making sure that they reduce their UV exposure. So the guidelines for BRCA2 is very much the same as for BRCA1, so I'm not going to repeat all of that. I'm just going to highlight the differences. So with BRCA2, the big difference is the ovarian cancer management, where they say that you can delay the risk-reducing salpingo ovarectomy until the age of 40 to 45, because we see a later onset and a lower risk. And then I also just wanted to say, so for our patients, in a South African context, if they're BRCA2 positive, we do actually recommend additional melanoma screening just because of what we've seen. So that would then be annual skin assessments and making sure that they reduce their UV exposure. So very important. We so focus on the cancer risks, but there's also autosomal recessive conditions associated with these genes. With BRCA2, it's been confirmed there's a definite association with anemia. And there is preliminary evidence for BRCA1. So what this basically means is that to have an autosomal recessive condition, both the mom and the dad needs to be a carrier for the baby to have a 25% chance of actually having this condition. It is quite a severe condition, as you can see from the features that I've listed. Abnormal thumbs, short stature, skin hyperpigmentation, there's abnormal facial features, and then there's also a chance that it might lead to bone marrow failure and also an increased risk for certain cancers. So if someone is positive for a BRCA2 and perhaps a BRCA1 as well, and they're still of reproductive age and they still want to have children, I always just inform them about this risk, and I say that it would be recommended to have their partner tested if they have a strong family history of BRCA1 or BRCA2 associated cancers, because if they are both carriers, then there is this risk to have a baby with this condition, and there are certain genetic testing options that we can offer. So they can either do the whole in vitro fertilization process with the PGTM, which means that they test the little embryos for the genetic change before they implant them, or they can consider testing during the pregnancy to make sure that the baby does not have this condition. So as a case example that I've sort of decided to do is I've decided to do things a little bit differently and focus on the men for a change. So Mr. G comes to see me for a consultation because he's a little bit worried. His sister, Mrs. E, was diagnosed with breast cancer at the age of 53, and back then, years ago, she was tested for the Afrikaner founder variant, and she was found to carry the BRCA2 variant. Since then, his brother, Mr. P, was diagnosed with pancreatic cancer, and he was also tested to see if he carries this BRCA2 genetic change. And the reason why he was tested is because obviously there's the option of the PARP inhibitors if you've got pancreatic cancer. So he was tested, fortunately, through the in vitro process, had the multi-cancer gene panel test. So I could offer Mr. G free of charge testing. Back then it was still free of charge, but since in vitro has changed their process, it's now charged at a handling fee of $950. So he provides us with a saliva sample and is tested for this family variant only. So I test Mr. G, and this is his result. So you'll just see that the in vitro does name the gene variants differently, but it is the same one, because if you look at the variant details, you'll see it's also known as 8162-G, which is what we use for this one. So now he is positive, which means he's also at an increased risk for breast, prostate, pancreatic, and melanoma cancers. But unfortunately, 2 weeks after we did the test, he actually phoned me and said he had a lump in his right breast. So I immediately said, you know, you have to go to the doctor, you have to have it tested. So he was diagnosed with stage 3 invasive ductal carcinoma. For me, it was a very sad story, but for him, he actually felt that this was a good thing, because he said he would not have been motivated to go to the doctor because of that lump if he did not know that he was BRCA2 positive. So he actually feels that it saved his life, even though we detected the cancer at a later, more advanced stage. So he had stage 3 breast cancer, so he had a modified radical mastectomy of the right breast, and he's currently undergoing chemotherapy. They do say that the cancer treatment for men is more or less the same as for women. So they do say that he could consider tamoxifen after chemotherapy for maintenance. So obviously, we wouldn't do like radical mastectomies of both breasts, because the recurrence risk is only about 1.9% for men with breast cancer. But he has to now continue monthly chest self-examinations as well as annual examinations by his GP. And he should also then consider an annual mammogram because of his past diagnosis. Other things that are important is it's also been recommended that he has PSA level blood test now, digital rectal examination. And very importantly, additional pancreatic cancer screening has been recommended for him because of his brother's diagnosis. And also additional screening for melanoma has been recommended. Now, it's very important to not just focus on Mr. G. So obviously, you should also now offer testing to the rest of the family members that's above the age of 18, because each child of a BRCA2 positive parent has a 50% risk of inheriting that variant, and with it, the associated cancer risks. So we offer testing for the family members. The younger generation got a fight. So you can see, doesn't happen often, but all of the men were now tested, even though they'd known about this gene for more than 10 years. They were all now motivated to be testing. And you'll see that luckily Mr. G's daughter does not carry it, so she does not need the prophylactic breast surgery. But Mr. P's 2 sons actually carry the BRCA2 genetic change. So for them, you would also offer additional cancer surveillance starting from the age of 40 for the prostate. The pancreatic cancer would start from the age of 50, and then the melanoma would be from the current age. And then you would also discuss the risk of Fanconi anemia. Then about the ATM gene, so it's also a tumor suppressor gene. It also helps to control the rate at which the cells grow, but it also plays an important role in the nervous and immune system functioning. And it also assists in recognizing damage or breaking DNA strands and repairing that. So very much the same function as a BRCA1 and a BRCA2 gene. So the cancer risks are different, but also very significant. Also just have to say that our knowledge about the ATM gene is not as good as our knowledge about BRCA1 and BRCA2. So these risks are changing on like a yearly basis at the moment because of all the studies that they're doing. But look at that female breast cancer risk. We used to think that it was a moderate risk gene, but now you can see that risk is actually can be as high as 60%. And then there's a very high risk variant that can give you a risk of about 69% to get breast cancer. There's not a lot of data on the contralateral breast cancer risk, but it's thought to be higher in patients who are younger. So obviously younger than 40 or even younger than 50. So the younger the patient is, the higher the risk is. There was some doubts about the risk for ovarian cancer, but it's now actually been confirmed that there is a definite strong association with ovarian cancer. It's not extremely high, it's 2 to 4%. There is a pancreatic cancer risk of about 5 to 10%. And very importantly, the prostate cancer risk for men is about 26 to 44%, which is very significant. There's also preliminary evidence saying that there's a gastric cancer, colon cancer, male breast cancer, and melanoma risk, but that is still very much preliminary. And just to also say, that with the ATM gene, it is a little bit different from the BRCA1 and BRCA2 because it's very, very dependent on the actual pathogenic and likely pathogenic variant that you have identified. That will determine in which risk category you will be put in on this little table, and it also very much depends on the family history. So what are the general guidelines? So if you are positive, very similar to the BRCA recommendations, but breast cancer, they used to say that you should only start screening from the age of 40, but now they've been seeing more and more younger women being diagnosed with breast cancer. And I mean, we're certainly also seeing that in our center. They're usually in their early 30s, early 40s at diagnosis. So they've actually now said that you should have annual MRI starting from the age of 30 to 35 years. And there's still a bit of a debate around prophylactic bilateral mastectomies, but that should be based on family history. So if you've got a family member that was very young at diagnosis and you see that this gene is very prevalent in this family, then you would obviously recommend that, and you use certain risk assessment tools to help you refine that risk. Pancreatic screening is the same as for BRCA1 and BRCA2. Ovarian cancer, at this stage, they're saying there's insufficient data to recommend risk-reducing salpingo ovarectomies for all women that are positive, but obviously, if there is a strong family history of ovarian cancer, that would definitely be a recommendation. I also say that that can also be a recommendation in women who are already in menopause, they're postmenopausal, they've completed their family, just because we know there's an increased risk. And we don't really, I know it's a 2 to 4% risk, but for that person who gets the cancer, it's 100% risk. So I would always say ovarian cancer is a very difficult thing to pick up. So it should definitely be considered if they're already in menopause. Prostate cancer, the screening is the same as for BRCA2. So other thing with ATM, there's also a risk for autosomal recessive condition called ataxia telangiectasia. This is a bit more severe than Fanconi anemia as it actually gives a reduced lifespan, and the majority only live up until the age of 25. It causes progressive gait and truncal ataxia, slurred speech, visual problems, radio sensitivity, immunodeficiency, also increased risk for certain cancers, especially leukemia. So the same process as for the BRCA genes. If they have a partner that has a strong family history of cancer, you would definitely recommend the carrier testing so that they could also benefit from reproductive genetic testing options if they want to. So as an example, so I have Mrs. A, she comes to see me for a consultation because she's now recently been diagnosed with invasive ductal carcinoma. It's hormone positive and HER2 positive. She's a healthy individual. She's a non-smoker, healthy BMI. She drinks 1 glass of wine over the weekends. She's very fit. She runs regularly. Her mom doesn't have anything, but she does have like a distant female relative. So her maternal grandmother's sister who had breast cancer at a very young age of 48, and her grandmother's other sister actually had prophylactic mastectomies at the age of 51. So it is a little bit suspicious. So we actually do testing. She agrees to do the multi-cancer panel. She wanted the full panel after discussion because she wasn't very sure about the family history and she didn't really want to miss anything because this was already a big shock for her. So after we do the testing, she's actually positive for an ATM gene variant. And you'll see from the variant details that they give that it's actually quite a unique variant that they haven't really seen very often, and it hasn't actually been reported in other individuals with ATM-related conditions. But it is a loss-of-function variant, so we know that it is going to disrupt the protein function, and that's why it's definitely pathogenic. So this is her result. So what do we do with it? So often we have different risk assessment tools that we use. So for the ATM gene, if it's a loss of function variant, CanRisk is a good model to use to try and figure out what is the risk of a second breast cancer. So the risk is usually for the contralateral breast and not for the breast that's affected. So you'll see that her risk for a second breast cancer is 40.8%. So it is significantly increased from the population risk. The population risk that's quoted there is the risk of another individual who has had breast cancer. So because of these risks, her risk is higher than 30%. So generally it's accepted to recommend bilateral mastectomies for a risk higher than 30%. Also, we know she's young, so all the literature is saying that the recurrence risk is higher in younger women. So we actually offer that, and she agrees to the surgery. And also, I mean, she also had a routine management of breast cancer. So she had the chemotherapy, and after surgery, she did receive radiotherapy because it is actually safe for carriers of ATM to receive radiotherapy. They were a little bit concerned about that in the past, but they've actually said that it is safe to give that. Or it's more beneficial to give radiotherapy than the risk of getting breast cancer again. And she's currently on tamoxifen. So how did we manage the risks for the other cancers? So obviously for the other cancers, there is a preliminary risk for ovarian cancer, but she wants to have more children, and also she's still very young. So we did not do that surgery at this stage, but we are now saying that she has to go for annual CA1 to 5 level blood tests and also the transvaginal ultrasound scan to monitor that. And once she's older and she's completed her family, we will review the guidelines to make sure what it says. But it would definitely be a consideration for the bilateral oophorectomies. For pancreatic cancer and for gastric cancer, no additional recommendations were made because she's got no family history of those cancers. The only one that I added was the melanoma, just because she is fair skinned, so she's already at an increased risk for melanoma, and now the gene on top of it. So for safety, I just said annual full body skin assessment and minimize the UV exposure. And I also counseled her about the risk for ataxia telangiectasia because her partner actually has a very strong family history of breast cancer. So it is important to test her partner to rule out that risk. So after that, obviously, we recommended testing for the rest of the family members. Only 2 individuals in this family had testing, and you can see the difference between this family and the BRCA family. The BRCA family had a lot of individuals with cancer, so those family members were more motivated to actually go for the testing. In this family, there was only 2 people that wanted to go for the test, her mom and her sister. So what have we recommended for them? So obviously the additional cancer surveillance as outlined. For her sister, we actually did a risk assessment, and it does show that she has a higher than 3% risk of getting breast cancer. But she is not in the space where she would want the surgery. So we're doing 6-monthly surveillance, breast surveillance on her. Her mother is doing additional breast screening. We wouldn't do surgery at her age. And also, we have recommended the bilateral salpingo oophorectomy to consider that, as she is already in menopause. And then for her sister, we actually discussed the risk of ataxia telangiectasia as well. Her sister doesn't want any more children though, so that was not a major concern. Then as my last slide, so I know it's a lot in a short space of time, but for my last slide, I just wanted to mention the PARP inhibitors, but there's not enough time to go into this in detail. So I wanted to alert you to this website because I think it's a very nice website that's updated regularly, that gives a nice summary of the FDA trials that's being, or the clinical trials that's being done, and what PARP inhibitors have been FDA approved and for the treatment of what cancers. So just to alert you to the fact that PARP inhibitors is actually FDA approved for treating not only breast and ovarian cancer, but also pancreatic and prostate cancer. And also it's been approved not only for BRCA1 and BRCA2, but in certain cancers, like for instance, ovarian and prostate, the ATM gene has also been approved. And those genes that I've listed there is the other potential genes that where PARP inhibitors might be helpful. So it's just important to keep this in your little toolbox if you're an oncologist and you're treating cancer patients. So just know that if you run out of options, if the person carries one of these genes, this might be an option. Okay, and that is my talk. So yes.